Cette vidéo traite de la problématique de la thromboprophylaxie en chirurgie non cancéreuse. Elle est présentée par le professeur Arcellus, qui est chef de service au CHU de Grenade en Espagne. C'est un expert mondial du sujet. Il a participé à de nombreuses conférences, en particulier la conférence de l'European Society of Anesthesiology en 2018 sur la thrombose et celle de l'American Society of Clinical Oncology en 2019.
And this is the brief outline of my presentation today. I will cover very briefly the difference of the screening DVT rate and the symptomatic DVT rate. I will address very quickly, since it was done already beautifully by Professor Caprini, the thrombosis risk assessment. I will remind some of the seminal studies on pharmacological prophylaxis, and I will try to comment what is the issue today of mechanical prophylaxis. I will stop a couple of slides on something that I consider very important, and that's how long is the risk of VT after non-cancer surgery. We have interesting data from Riete, and we will conclude with the main recommendations. So, what is the incidence of the postoperative DVT? Well, in the 80s and 90s, a number of studies with routine screening with fibrinogen update test or with venography showed a pretty high rate in patients without prophylaxis, about 25% in the general surgical population, 20% without cancer, almost double, 37% in those operated for cancer. But those figures are different today, and today we pay more attention to symptomatic VTs. Those are the ones that we treat. So the current data establishes that on average, up to 1 month after a major operation, we can expect around 2% DVT or VT rate, symptomatic VT rate. But this will, of course, depend, as we see here, the range 0.5 to 6% on the patient characteristics, on the operation, and very important, the duration of the follow-up. The longer we follow the patients, the more VTs we found. Patients' characteristics and operations were beautifully addressed by Professor Caprini before. Actually, this is the ACCP table regarding the Rogers score and the Caprini score, both for general surgery and, importantly, for plastic and reconstructive, and many cases of important abdominal wall reconstructions, body contour surgery, abdominoplasty, etc., are in this field where, as you can see, the rate in the high-risk Caprini category can be even higher than in general surgery. Of course, the risk of bleeding, we have always to balance the risk of thrombosis with the risk of bleeding, as already heard, and we should never forget this list of conditions that would preclude or would make us to be very cautious with the use of anticoagulants. This is basically the same list shown in the ACCP guideline, but this is the one included in the recent Mayo Clinic review that I will address in some other slides.
Alors oui, dans les situations à haut risque en chirurgie non cancéreuse, il faut aussi avoir à l'esprit que parmi les facteurs de risque liés aux patients, il y a les antécédents de cancer. Et ce risque est d'autant plus important que le cancer est récent ou qu'il est encore actif.
We have large data. This example, the meta-analysis by Patrick Mismeti, those are 48,000 patients included in 51 trials, comparing low molecular weight heparin with unfractionated heparin. And as we see here, and we stratify in yellow cancer, in green non-cancer, at that time when this study was conducted, they were similar with some trend in favor of low molecular weight heparin, both for cancer and non-cancer, with a low rate of bleeding that again was similar. So it has been established that pharmacological prophylaxis with low molecular weight heparin is safe and is very effective.
On pourrait compléter ce message en rappelant que les anticoagulants oraux directs peuvent aussi être utilisés pour prévenir la thrombose veineuse en post-opératoire, en chirurgie après prothèse totale de hanche ou après prothèse totale de genou, et uniquement dans ces indications chirurgicales-là.
What about mechanical methods? What are the current indications for mechanical methods that are probably overused in North America and underused in many European countries? Well, the main indications are in combination with pharmacological methods in very high-risk patients, multiple trauma, cancer patients, some obesity procedures, and of course, when anticoagulants are contraindicated. And the endorsed study showed us that 10% of patients with formal contraindications to receive anticoagulants should receive mechanical methods. 10% of high-risk thrombotic patients cannot receive pharmacological temporarily or permanently. We shouldn't forget that they have also contraindications. You cannot use intermittent pneumatic compression in a patient with a DVT, recent DVT, because of the risk of breaking the thrombus and causing a PE. Similarly, you should be careful with stockings in patients with arterial insufficiency or patients with fragile skin wounds, or peripheral neuropathy. Also very important to remind that when you indicate mechanical methods, you have to be very careful that the nursing staff is applying those methods properly. Many times the compliance is not, and the adherence is not adequate, not by patients, by the nursing personnel.
Alors, il faut faire la distinction entre prophylaxie, entre les bas de contention et la compression pneumatique intermittente. On va y revenir après, en sachant que tous les centres n'ont pas forcément ces systèmes de compression pneumatique intermittente.
What about the combination of pharmacological methods and stockings? Well, we have been advocating this for many years, but rather empirically sometimes, until we had this interesting study done in the UK, 2,000 patients, 84% at high risk for thrombosis, 22% with active cancer, and here they compare in 1,000 cases. Low molecular weight heparin alone, and in another 1,000 patients, heparin plus stockings. Follow-up up to 3 months, symptomatic cases were searched for, and as you see here, although there was a minimal reduction in the combination group, it was not significant. Actually, there was a significant non-inferiority, so they were the same. And the authors of the study conclude that in this population, or similar that they analyze, it doesn't has a real benefit adding stockings to.
Les recommandations de la Société européenne d'anesthésie de 2018 limitent l'utilisation de la thromboprophylaxie mécanique, que ce soit les bas de contention ou la compression pneumatique intermittente, à 2 situations. Premièrement, c'est en cas de risque élevé, c'est en association avec les anticoagulants uniquement. Et deuxièmement, c'est en cas de contre-indication aux anticoagulants, en privilégiant la compression pneumatique intermittente plutôt que les bas de contention. Et en dehors de ces 2 situations à risque élevé, les indications des bas de contention sont vraiment à discuter au cas par cas.
I want to pay attention now in the next 2 slides, and it's a pleasure for me to share with you this data from our own study based on Riete. Here you have 3,300 patients that develop a symptomatic VTE in the first 8 weeks after an operation for a benign condition. So the first message is that the median time from the operation to the VT detection was 16 days, not 4 or 5 days, 16. Actually, 1/4 of the patients presented the problem after 1 month, as compared to 38% in a similar series of cancer patients. But as you see, 1/4 late presentation. Only 44% had received pharmacological prophylaxis. All of them had VT, as I said. 2/3 were detected after prophylaxis was discontinued. The median duration of prophylaxis was 8 days. So it's clear that prophylaxis probably one of the reasons prophylaxis was not effective is the duration, because the dosing seemed to be okay. Also important about the outcomes, 54% presented as PE and 15% had a bad outcome in terms of recurrences, death, or bleeding. Here you have the presentation, the number of cases by weeks, and here you see a first peak in the first 3 weeks, followed by a reduction in the second period of 3 weeks, and then without reaching 0, kind of establishing a plateau about the 3rd month, very similar to the study from Switzerland in the UK.
Alors, comme il le rappelle, ce risque majeur les 3 premières semaines et qui persiste jusqu'à 12 semaines après la chirurgie Il est connu depuis une grande étude anglaise qui date de 2009 sur plus d'1 million de patientes. Et les données, elles poussent donc à prolonger la prophylaxie à 3 ou 4 semaines après une chirurgie non cancéreuse à haut risque ou pour des patients à haut risque. Donc, il ne faut pas hésiter dans ces deux situations-là à prolonger la thromboprophylaxie. Et ce sont les recommandations de 2019 de la Société américaine d'hématologie.
Here you have on the right, in blue, the percentage of patients who develop PE, in orange, those with DVT. As you see, at the beginning, PEs are more prevalent relatively to DVTs, and then they almost equalize. Regarding the operations presenting as DVT or PE, again, in patients without cancer, we see that those with a higher relative rate of PE were bariatrics, cholecystectomy, intestinal problems, and those with a higher relative rate of DVT, were C-section and neurosurgery. So I think this study highlights that this is also a problem after non-cancer surgery, and probably we need to consider extended prophylaxis in some of these patients. Very briefly, hernia surgery is catching attention these days. Of course, the typical approach for inguinal hernia repair is associated with very low rate of DVT. Although, think about it, with Caprini, if the patient has additional risk factors, the risk goes up. Hypercoagulability has been documented in abdominal wall surgery as well as stasis. Here you have this image. This is the retroperitoneal endoscopic approach, and this is the collapsed iliac vein. This is the nerve, and this is the iliac artery. So this gas causes a collapse of the vein stasis, and here you see some shadows in the heart showing a PE passing during this operation. Abdominal wall reconstruction, particularly in the obese patients, is associated with a very high rate as well as abdominoplasty. And as you see here in this study, analyzing 1,700 patients with undergoing in the N-squib abdominal wall repair, here you see that in those with class 3 obesity, the rate of BTE was almost 4% as compared to 2.4% in class 1 obesity of 0.8%. So in abdominal wall surgery, the presence of obesity increases dramatically the risk. Christopher Panucci has created, based on 113,000 ventral hernia repairs in the US, an stratification model specifically for this operation. Inflammatory bowel disease has been shown to have a risk of VTE even higher than colorectal cancer. As you see here in this study with 45,000 patients from the N-squib database in the United States, the rate in the first 90 days, the rate of VTE was 26% higher after inflammatory bowel disease, particularly ulcerative colitis. And very importantly, the rate of late VTEs after hospital discharge is also even higher than after cancer surgery. So we have to pay attention to this population. I'm concluding with the main recommendations for this non-cancer. Well, we had 2 years ago a rather complex but very comprehensive guideline from the American Society of Hematology. There are more than 18 recommendations, and this does not cover oncologic or non-oncologic. No, it's a little bit difficult to interpret. It's surgical patients. But anyway, here, of course, they say that in patients with a high-risk bleeding, you have to rely on mechanical methods. Regarding extension, and I think this is important, the panel suggests extended antithrombosis prophylaxis, and that's for them over 3 weeks. And they don't talk here of abdominopelvic cancer. They talk of high-risk surgery. I think this is in line with our findings from Riete. Some non-cancer surgical patients will benefit, but it has to be proven in randomized trials. About the timing, they recommend starting post-operatively, and they go more for 12 hours after the operation. And although they don't recommend routine prophylaxis for lab coli for benign conditions, they acknowledge that other patients with additional risk factors could benefit, again, A risk assessment model here would be very helpful. What about fast-track surgery? Well, 4 years ago, European Society of Anesthesiology provided some empiric guidelines, since we don't have a lot of studies on day surgery or fast-track surgery, but basically they recommend general measures for all patients: early ambulation, good hydration, good pain control, and adding pharmacological prophylaxis in patients with high risk because of their factors of high risk surgery. About timing, they recommend a minimum of 7 days, although some populations could benefit of shorter periods and some populations could benefit from longer periods.
Effectivement, alors que pour l'ambulatoire, on sait déjà depuis longtemps que le risque thrombotique est diminué, on manque d'études dans le cadre de la réhabilitation améliorée après chirurgie. Et dans le cadre de la RAC, en plus, le peu d'études qui ont été faites, elles ne prennent pas en compte l'adhérence au protocole RAC, aux items de la RAC. Donc, c'est difficile de les comparer et d'en tirer des données suffisamment claires et des messages clairs. Alors, il y a quand même une étude de 2020 qui a montré que la chirurgie mini-invasive, que ce soit la cellio ou la chirurgie robotique, réduisait le risque thromboembolique.
Well, about IBD, as I mentioned, a very high risk situation. Well, the recommendation from the American Society of Colorectal Surgeons, recommendation number 6, says that in patients with IBD at high risk for DVT, selected patients would benefit from extended prophylaxis after hospital discharge. So to conclude, dear colleagues, this is, I think, a nice recommendations from the Mayo Clinic review. What would be a nice approach to VT prophylaxis today? Well, before the hospital admission, we have to assess the risk for thrombosis and bleeding, and of course, optimize the patient and conduct a physical and a good history. Upon admission, decide if the patient is going to start with preoperative prophylaxis or not. This is very important if the patient is going to be admitted for 5 days before surgery is conducted, because sometimes patients are transferred from one department to the other. Intraoperatively, good anesthesia, short operation as much as possible, less invasive approach would help a lot. And postoperatively, again, what I mentioned, early ambulation, good patient control, good hydration, and good compliance with pharmacological and particularly mechanical methods. At the time of discharge, we have to reconsider the need for prophylaxis, extended prophylaxis, and as you heard Professor Caprini, the score can help you to make that decision. And of course, you have to educate patient about that prophylaxis as well as the relatives. So in conclusion, as you see, this is a dynamic process, both for VTE and for bleeding risk that needs to be evolved, needs to be applied almost on daily basis, and the prophylaxis should be adapted to that situation and to that estimated thrombosis and bleeding risk. So thank you very much for your attention.
Alors en conclusion, ce qu'on peut dire, c'est que pour la prophylaxie antithrombotique périopératoire, il faut évaluer en préopératoire le risque thrombotique, mais aussi le risque hémorragique. Les deux sont à mettre en balance, en prenant bien en compte aussi les risques liés au patient. Ensuite, il faut prescrire une prophylaxie préopératoire uniquement dans certains cas particuliers. Par exemple, c'est une hospitalisation de plusieurs jours avant la chirurgie. Il faut optimiser la prise en charge péropératoire, donc il faut des durées d'intervention les plus courtes possibles, et en associant si possible des techniques mini-invasives. Il faut faire déambuler le patient rapidement après la chirurgie et surveiller l'observance des prophylaxies qu'on a prescrites, qu'elles soient pharmacologiques ou mécaniques. Il faut bien rediscuter à la sortie l'indication d'une éventuelle prophylaxie prolongée, donc au-delà des 7 ou des 10 jours classiquement, mais à prolonger jusqu'à 3-4 semaines en post-opératoire. Il faut bien éduquer le patient pour qu'il suive les prescriptions antithrombotiques.